Right, but welcome everybody. Welcome to Boulder Center for Orthopedics and Spine lecture series. Tonight we get to hear from Dr. Yerrapragada. So let me give you a short intro to who he is. Dr. Yerrapragada earned his Bachelor's of Science degree from the University of Texas at Austin. He attended the University of Louisville School of Medicine in Kentucky to complete his Doctor of Medicine degree. He completed his orthopedic surgery residency at the University of Washington in Seattle, where he trained at Harborview Medical Center, one of the best trauma centers in the country. Afterward, he committed to an additional year of fellowship training in orthopedic foot and ankle surgery at MedStar Union Memorial in Baltimore, Maryland. So please welcome tonight, Dr. Yerrapragada.
Thank you, Sally, and I appreciate everyone taking time out of their day to sit down and take part in this educational lecture with me. I'm going to go ahead and share my screen. Let me go ahead and get started. Sally, does this look okay from your end?
Yes, everything looks perfect.
Great. So tonight's lecture, what I'll be going over is treating ankle arthritis and talking about specifically total ankle replacements. So I wanted to thank Sally Brown for helping organize this, as well as my partners at ExactTech in helping organize this seminar. As Sally went over, in brief, my training started back in Texas at the University of Texas, and then bounced to University of Louisville in Kentucky, where I did my medicine degree. I went to Seattle, Washington, and trained at University of Washington for orthopedic surgery, and then did an extra year of foot and ankle surgery at MedStar Union Memorial Hospital in Baltimore, Maryland. As listed below, I treat essentially all different types of foot and ankle conditions, but tonight we'll specifically be talking about total ankle replacement in the setting of arthritis. So we'll go ahead and start with ankle anatomy, then kind of go over some basics of ankle pain, talk about ankle arthritis in particular, talk about some treatment options, and then talk about the surgical options that it may lead to eventually. So we'll briefly go over the ankle anatomy. The ankle is a hinge joint that involves three bones, the tibia, the fibula, and the talus. And as that animation on the right is showing, it articulates in up-down motion, which is what we call dorsiflexion and plantar flexion. There's many soft tissue structures that help stabilize the ankle, including many ligaments, tendons, and capsular structures. But in general, it involves those three bones, the tibia, the fibula, and the talus. So when it comes to ankle pain, there's a lot of different causes, and it's really hard to talk about all of them in one lecture. But in general, one of the more common causes is osteoarthritis. Now, you all may have heard of osteoarthritis. This is a condition that can involve any joint, and more commonly involves joints like the hip and the knee. But ankle arthritis is still common enough and very prevalent, and it's in layman's terms a degenerative joint disease where cartilage that cushions the end of the bone wears down over time. Now, when we talk about osteoarthritis, it's almost always involving older individuals who over many years have accumulated wear and tear of their joint over time. Now, some younger individuals can develop this as well. And this is often post-traumatic, meaning after a fracture, severe injuries, multiple ankle sprains, or if they have underlying genetic conditions that predispose them to developing osteoarthritis. Another type of osteoarthritis is what we call rheumatoid arthritis. And this is an autoimmune inflammatory disease that involves multiple joints, and the ankle is no exception here. Post-traumatic arthritis, like I mentioned before, is something that develops after an ankle injury, typically a fracture or a sprain. And even if the fracture is fixed very well, the injury that was sustained to the cartilage at the time of the fracture can be significant enough that it leads to wear and tear of the cartilage over time, resulting in arthritis. Another common cause or another cause of ankle pain is avascular necrosis or osteonecrosis. And what this is the blood supply to the bone is disrupted in some capacity, leading to collapse of the bone and subsequently the collapse of the cartilage attached to it. So this often occurs in the talus bone, typically after talus fractures of certain types. because the blood supply to the talus is tenuous. And because, if you recall, the talus is part of the ankle joint, this can lead to arthritis of the ankle joint and severe pain. Other causes of ankle pain: severe ankle injury, fractures, which, like we mentioned before, can lead to arthritis. Or if you have a severe enough injury, you can lose bone stock, and you can have bone deformity resulting in many cystic changes in the joint, changes in your alignment over time. And deformity that results from that bone loss can be something that needs to be corrected at the time of surgery. Otherwise, it can affect other adjacent joints, including in your foot and higher up in your knee and your hip. So specifically talking about ankle arthritis, like I mentioned before, the ankle is made up of many various bones, ligaments, and tendons and cartilage that connect at the junction of your leg and foot. It's a hinge joint that moves your foot up and down. While the bony structures are important in making up the ankle joint, the ligaments holding them together on the sides are what provide your stability. What's most important when it comes to arthritis is the cartilage, though, meaning that's what allows our joint to move up and down very smoothly. Now, the amount of friction in two cartilage surfaces is akin to two cubes of ice rubbing against each other. And if you imagine that, it's very, very smooth. And that's about the lack of friction that's present with your joints when you move them up and down. As you lose cartilage over time, you start to develop bald spots, and if it gets really bad, the entire surface of cartilage is lost, and you get what we call bone on bone arthritis. And that smooth gliding surfaces of two ice cubes quickly degenerates into a jagged, rocky surface that results in pain, swelling, inflammation, and can develop some catching and locking symptoms as well. The most common cause of ankle arthritis is post-traumatic arthritis, meaning in the setting of a previous injury. Now, this is very different than other joints. So if you look at knee arthritis or hip arthritis, or even shoulder arthritis, the most common cause is just wear and tear over time. But for whatever reason, the ankle joint itself, normal wear and tear arthritis, is not as common as post-traumatic. And unfortunately, with the amount of injuries that our ankles can sustain, like severe sprains, fractures, this is common enough to result in development of severe arthritis. Now, like I mentioned before, osteoarthritis is the degenerative changes over time, and age is the most common reason. Just like the other types of arthritis, the fundamental underlying factor when it comes to this is the cartilage wearing out over time. But like I mentioned before, other types of arthritis, such as gout, pseudo-gout, septic arthritis, can play a role in the development of some arthritis as well. Now, rheumatoid arthritis is a tricky type of arthritis because it involves multiple joints, and it's not as simple as just treating the ankle itself. You have to take into account the other joints that may or may not be involved. Typically, with more severe rheumatoid arthritis, the patients with this are often very limited, and because of the severe arthritis involving the multiple joints, so they're relatively low demand. But what's interesting is that nowadays, in the last 10, 20 years, the amount of patients who develop end-stage arthritis due to rheumatoid arthritis has steadily been decreasing due to the revolution in disease-modifying drugs that has really changed the disease process. So it's certainly not as common as it was before, but still out there. So now we talk about common symptoms. So of course, the most common symptom here is pain. When it comes to arthritis, about 25% of folks report some type of severe pain. As the disease progresses, though, the pain typically increases. But what is really interesting to note is that the amount of arthritis seen on X-ray does not correlate at all to the pain, meaning there are plenty of patients with really severe pain due to arthritis with not so severe looking X-rays, and the opposite is true, meaning patients with severe arthritis on X-ray, some of them may not have pain, but typically it does tend to correlate with the severity of arthritis present. Another common finding is stiffness. So if you imagine that smooth surface gliding, as that cartilage wears out, the bone starts to rub on bone, and bone is an irregular surface. It's not smooth. So you start to develop decreases in range of motion. Our body's natural response to pain and inflammation is to develop bone spurs. And what these bone spurs are doing is to try to increase the surface area of that joint by making extra bone. By doing so, it decreases motion. So the spurs that our bodies typically develop with arthritis are actually a protective mechanism, but it can lead to stiffness. That swelling that I mentioned before, that's possible with arthritis, that's due to inflammation, and that's from the bones rubbing on each other. Crepitus noise, as stated here, is that popping, catching, grinding type sensation that you can feel when joints become bone on bone. In really severe cases of arthritis, you can develop instability or deformity, and meaning as the bone starts to rub on each other, it can wear and erode irregularly in the ankle joint, leading to severe deformity. And people talk about having knock knees or bow-legged knees. The same can happen in the ankle too, if the arthritis gets bad enough. So it's when you're talking to a patient or evaluating someone for ankle arthritis, really important to get a good detailed medical history. Typically, the symptoms are activity-related pain, usually worse at the beginning of activity, meaning you get up, it's stiff, it's tight, you loosen it up a little bit, it starts to feel better. But as the disease process progresses, it can become daily pain with every step and pain with worsened activity. On exam, you'll see swelling, you'll see tenderness to touch around the ankle joint, limitations in range of motion, all consistent. The most important type or of information to get, however, when diagnosing is an X-ray, and an X-ray will give you indication of how bad the arthritis is. Now, it's really important to get a weight-bearing X-ray, and if anyone asks you to get an X-ray or gets an X-ray that's non-weight bearing, it doesn't really give us the true sense of how bad the arthritis is. And if you imagine, if you're putting weight on a joint, you're actually compressing it. And that is where we live our life is on our feet. So that's when we have symptoms. If we do, it doesn't do us much good to have a laying down x-ray. It doesn't give us as much information as a weight bearing x-ray. Things like CAT scans and MRIs can give additional information if the x-rays are subtle and not quite diagnostic, but x-rays is usually the first step. Visual inspection, this goes along with physical exam. This will tell us the extent and how bad the severity of disease is. And if you're looking or thinking about something like a rheumatoid arthritis, then you can do types of laboratory testing or blood work and even analysis of the fluid that you can draw from the joint. Now, it's important to check and make sure, especially in someone if you're considering a surgery, is to make sure that they have good blood flow, and it's assessing the pulses in the foot. Now, if there isn't great blood flow, history of vascular disease, then any surgery you may offer someone is unlikely to do well because things have to heal, and the way things heal is getting it through the blood. So you really have to make sure you have adequate blood flow before ever venturing down the path of surgery. So when we talk about bone deformity or loss, it's one of those rare cases, or let's say uncommon cases, where the severity of the ankle arthritis can be markedly affected by the bone deformity or loss. Now, there's many or key aspects of bone deformity of the ankle: altered shape or size. The bones become misshapen, leading to irregular joint structure. And if something that normally should be lined up parallel to each other, if there's any irregularities, even slightly, over thousands of steps every day, that irregularity can compound, leading to accelerated arthritis. Now, another key factor, especially as we age, is decreased bone density. So in conditions like osteoporosis, loss of bone mass can make bone fragile, more prone to fractures as well, and also weaken the bone around the adjacent arthritic joint. Joint misalignment. So if you imagine when you're standing up, the ankle isn't, there's joints above the ankle that can affect it. So if your ankle isn't quite lining up straight like you expect it to, it may not just be the ankle itself. It could be the knee or the hip. If you have irregularities there, that could be throwing off the shape of the ankle. So in my position, it's really important to assess the patient's overall alignment before making judgments about how to correct their ankle deformity. Things like chronic pain, discomfort, these can be or definitely associated with arthritis, but you have to be careful that it may be related to other chronic conditions that may be mimicking or simulating arthritic type pain. We talked about reduced mobility. This can be caused by bone deformity or by severe arthritis. And in general, if you do have arthritis or you have significant deformity, you do have an increased risk of fracture. And the way you think about that is, if your ankle isn't perfectly lined up, if you're off due to deformity or malalignment, then if you twist your ankle, you fall, the normal protective mechanisms that stabilize your ankle, preventing it from hurting, are compromised, leading to potentially increased risk of fracture there. Here are some examples of x-rays of arthritic joints. And it doesn't take a trained radiologist to take a look and to see that these joints aren't quite, what they should be. If you look at the far left, you see the tibia bone, the fibula bone, and the talus bone. But what's interesting here is this talus bone should be parallel to the tibia bone here, but it's not. And you can see that deformity there. That's that part of that bone loss that we talked about. And right here where my cursor is pointing, that is where you have bone-on-bone arthritis. This is the front view of the ankle. The next image is a side view of a different ankle, and you can see here how the curvature of the talus bone on the side doesn't quite match up to the curvature of the tibia bone on the other side. That's due to bone loss, chronic deformity, and over time, the bone-on-bone arthritis has gotten to a point where this patient has developed a lot of bone spurs throughout the front and the back of the ankle. Patient on the right, this is an example of post-traumatic arthritis. You can see the previous holes in the bone on the fibula side from screw tracks over time. You can see a healed fibula fracture there. Again, multiple screw tracks through the fibula and tibia. But despite proper fixation of the fracture over time, the joint itself is worn out dramatically. You can see there's no more joint space left between these two bones. And this is due to post-traumatic arthritis in the setting of a fracture. So now that we've kind of gone through the history and some imaging, now we're leading over to the treatment side. And this is where we first talk about non-surgical management. And the majority of these patients are treated non-surgically. A handful are the ones that progress to surgical management. First line treatment are things like anti-inflammatories, NSAIDs. You've seen them as ibuprofen or Advil, naproxen or Aleve. These anti-inflammatories are really helpful in decreasing inflammation. I mentioned acetaminophen here or Tylenol. Now that's helpful for pain relief, but when it comes to affecting inflammation, acetaminophen or Tylenol does not do a good job of decreasing inflammation. It's more of a pain reliever. So things like ibuprofen or those types of family of medications do help, especially in the early stages of the disease. Physical therapy can certainly help as well. And this focuses on improving range of motion and strengthens the muscles around the joints so that you're compensating less and that less stress goes across the joint itself. One level up from physical therapy is supported bracing or orthotics and shoes. And there are many different types of ankle braces to provide support. But the function of these braces, especially as disease progresses, is to limit the motion of the ankle. If you imagine in setting of arthritis, when it gets to bone on bone, the more the bones rub against each other, the more painful and inflamed they can get. So by wearing these supported braces, you're functionally decreasing the motion of the ankle, but it's almost certainly a temporary fix. Now, many of you may have heard or have had corticosteroid injections in different parts of your body. Corticosteroid injections have been shown to be great pain relievers for multiple joint type conditions, in particular arthritis. And you can inject many different joints, and the ankle is no different. But with all corticosteroid injections, they are almost always temporary in pain relief. You can have multiple injections, but typically over time, the effect of each injection decreases. So what I tell my patients is we can certainly start injections and we can inject until it stops working. But once we start, we are marching towards a point where the injections may not work for anymore. And you're stuck with the decision of, can I live with this pain with the non-surgical options, or do I need to do something about it with surgery? Now, historically, there are two main ways to treat ankle arthritis: ankle fusion and ankle replacement. Ankle fusion is what it sounds like. You are eliminating the joint and fusing the bones of the ankle joint together. Now, if you had asked, or if I had this lecture 30 years ago, the majority of patients would be doing ankle fusion. In fact, ankle replacement would be very, very small on that list. The majority of her are doing ankle fusion. But in the last 30 plus years, ankle replacements have become more popular. They have become better designed and better tolerated. And nowadays, the majority of patients are getting ankle replacements. Now, there are still patients that are good candidates for ankle fusions, and I'll talk a little bit about that. But the majority nowadays are getting an ankle replacement, which involves removing the cartilage that's left, the arthritis, putting metal caps above and below the joint with a plastic spacer in between to let motion of the joint. So, like mentioned before, in ankle fusion, the ankle bones are fused together, limiting motion of the joint. A combination of plates, screws, and rods can hold these bones together until they're healed and become one bone. The main purpose of this procedure is to eliminate pain from the arthritic joint, and it does a good job of that once the bone is fully fused. The outcomes, it does a really great job of relieving pain and it improves stability. If you imagine the ligaments around the ankle, they're not necessary anymore because you don't have any motion there. So once the joint is fused, it becomes a really solid block of bone, and it really does a great job of eliminating pain and giving a lot of pain relief. So the types of people that do really well with ankle fusions instead of an ankle placement, imagine as someone who is very young. So in patients that are very young, we're talking 20s, 30s, 40s, who have really severe ankle arthritis and they're very high demand. And what that means is they are working construction, they're working manual labor, they're lifting heavy things, they have to pound and use their ankle a lot. Ankle fusions are actually better for that type of population. If you imagine with an ankle replacement with that plastic spacer over time, that spacer does wear out. And the more demand you put on it, the faster that can happen. So that type of population are the ones typically that get an ankle fusion if it's necessary. Another population or subgroup are those that are sicker, meaning they have other comorbidities or risks of wound healing issues, such as patients that are diabetic or have other types of peripheral neuropathy, where the risk is that their wounds may not heal well, which if you put an ankle replacement under a non-healing wound, it's a high risk of infection. So those are the types of people that typically get an ankle fusion over a replacement. Other outcomes from an ankle fusion is the risk of adjacent joint arthritis, which is number 2 here on the slide. If you imagine if you lock a joint in place and it can't move, the other joints adjacent to it have to compensate. And over thousands of steps every day for years, those adjacent joints will wear out quicker over time. So you will notice things like what's called subtalar arthritis, which is the joint below the ankle, as a common next thing that can happen after an ankle fusion. But that does occur over many years. It's not an immediate thing. So it does take time for that to develop. The limited range of motion is a big one. And if you imagine that up-down motion of the ankle joint is totally eliminated. Now, about 20% of that up-down motion can be compensated from the adjacent joints. So if you see someone with an ankle replacement and you see their ankle moving up and down, it's actually from their foot. So if my wrist is my ankle, my fingers are the middle of the foot, those joints can actually compensate a little bit. So you get some motion, but not a lot. So the patients who love to ski, for example, you can't quite get into ski boots because you can't point your toe down. They do make special customized boots to get you in, but it's that limited motion is something that people have to get used to. In terms of recovery and rehab from an ankle fusion, it is a longer rehab upfront, meaning you have a longer period of time that you're non-weight bearing because we have to get the bones to fuse together before we can let you safely put weight on it. And that does take time compared to an ankle replacement where we're usually letting patients put weight on it between 2 to 4 weeks, depending on the surgeon, depending on the implant. So this leads us to ankle replacement, which has become the more popular option for ankle arthritis surgery over the last, I would say 10 to 15 years is when it has become more popular. It's been around for more than 30 years. The first descriptions of ankle replacements are back in the 70s and 80s, but those are really primitive early generation implants that we have since improved upon. But it didn't really catch on until the 90s when instrumentation and technology quickly improved. And, the design engineers who were looking at ankle replacement took things from knee replacements and hip replacements to learn from errors that they had previously made to improve upon it. Okay. An increasing number of patients nowadays undergo ankle replacement to maintain that motion and, more importantly, keep their function as high as it can be. The ankle replacement that's seen here, though the white on that X-ray is the metal itself, and that space between the two white components of the tibia and the talus, that's the plastic spacer, which you can't see on an X-ray, but that allows patients to move up and down. Technology is always improving and always getting better. And so nowadays, what people like to use, or a lot of surgeons like to use, is this patient-specific instrumentation, which The company that I like to use, Exactech, allows me to do. So what we do is we get CAT scans of the patient's leg from the knee down to the foot, and that allows us to make patient-specific cut guides that is custom made for the patient to allow for a more symmetric and congruent joint, more accurate cuts that are a little more precise, and also decrease the time in the operating room. Let me show you, or before I show you, I'll talk a little bit about the evolution. Like I said, in the 70s, the first generations came out very primitive, rudimentary, limited success. They didn't quite have the same success that we're seeing nowadays. Over the next 20 years, the design and techniques continue to improve. But even then, these early prostheses still had issues with wearing out very quickly and needing revisions at a relatively young age. In the 2000s and over the last 10 years, the technology has advanced pretty dramatically. We're on the fourth generation of implants, and we're embarking on the fifth generation as we speak. And what's happening is that the materials, the implants, and quite frankly, the surgical techniques are improving to a point where it's pretty reliable, and these implants do last a good amount of time. Some of the best data we have is that the implants that were placed over 20 years or 20 years ago, somewhere in the range of 80 to 90% are lasting that long. And these are implants that were placed 20 plus years ago. So as things continue to improve, the duration and the longevity of these implants is currently improving. So here's an example of what the surgery looks like, frankly. So you start by making an incision over the front of the ankle, and once you get down to bone, this is not using the patient-specific instrumentation. So this is an example of using the patient's native tibial alignment, where you place a alignment guide on the front of the tibia. It's going to zoom out and show you that there's an anchor point at the top of the tibia to make sure that you are cutting in line with the bone itself. You're placing several pins to anchor this guide, and then you're using a saw to go in there and literally shave and remove the bone. You're shaving and removing the bone because attached to that bone is where the cartilage once was and no longer is. So using a combination of saws, you remove the guide, then remove that piece of bone, and that's from the tibial side. You repeat this process with the talar side. So same thing, maintaining that alignment that you measured using the tibia. You make cuts in the talus using a saw. You remove the guide and then remove the bone. And once you have that removed, you have this square block of real estate in which you use, or you make different holes and different chamfers to allow that prosthetic implant to sit on. This is one of the guides that we use to make sure that the shape of the tibia is appropriate. You're punching holes in the bone, and these holes are what are used to anchor that talar implant in place. Same thing, you have to make corresponding holes on the tibial side to allow for that implant to sit in. And what's interesting about these implants is the undersurface of these implants, they are porous coated, meaning there are many holes in it that allows for bony ingrowth. And over time, your body's bone actually grows into the implant, which helps stabilize it and prevents it from loosening and prevents bad things from happening. You see here the implants going in on the tibial side and the talus side, and that plastic spacer is the final component that slides in the middle to allow your ankle to move up and down. So in terms of surgical outcomes for ankle replacements, the pain relief and improved mobility, the majority of patients have dramatic improvements. Ankle replacement surgery, it's the purpose of it in relation to a fusion is to maintain or improve ankle range of motion. Now, in certain situations, you certainly can improve it, but what often is the case is your range of motion will never be what it was when you were 20. And that's because over time, due to the arthritis, the soft tissue around your ankle joint has gotten used to that, whether it's stiff or swollen position. But you can definitely improve it and maintain it. So the main goal is to maintain some motion so that you can remain functional, get into certain shoes, do the activities you want to do. The quality of life from the studies that have measured this dramatically improves, mostly due to the pain, and that maintain motion to allow people to perform daily activities. In general, the types of restrictions after total ankle replacement, what I tell folks is you can do most things, but if your life or your goal is to be marathon runner, long distance runner, that type of thing, the more repetitive impact activities can wear out the implant quicker over time. But the patients that are coming for ankle replacements, they've been dealing with ankle arthritis for many years, and it's progressed to a point where they haven't been able to do those activities in a long time. So these patients are typically just content with being able to walk, hike, cycle, ski, snowboard, these type of activities that doesn't involve that repetitive high impact activity. In general, the recovery time is very variable, but it's about 2 to 4 weeks of non-weight bearing, after which patients have progressive increase in weight bearing. The full recovery, just like any joint replacement, what I tell folks is 6 months to a year, somewhere in that time frame before you're feeling 100%. You're walking on it well before, and at least for me, I have you in physical therapy starting at 2 weeks, really working on it. But that overall improvement of, hey, this is feeling really good again, 6 months to a year, but you're making progress throughout. Like I mentioned before, the longevity of the implant, the best data that we have in the literature is from implants put in 20 plus years ago, and 80 to 90% of these implants are surviving. So that we don't know how far out that they will continue to survive. And like I said, the implants have improved since then, but we're always making improvements. It's always continuing to improve. So that's around the time frame that I quote patients. And the corollary to the issue or the side effect of an ankle fusion is that adjacent joint arthritis. Because that ankle joint has maintained motion now, the risk of the adjacent arthritis is dramatically decreased, because there's a compensation of that ankle joint that prevents the stress on the adjacent joints there. So I mentioned Exact Tech and the Advantage Total Ankle. This is the ankle replacement that I use. So there's a few different types of implants on the market, and the Exact Tech Advantage, that's the one I typically use. And when I bring patients into my office and talk to them about ankle replacements, I show them the model of the ankle replacement that the Exact Tech team provides, and it's got a few important design traits to it that I think are well designed. If you look on the left side, the historical design was very block shaped, bulky, not exactly form fitting to what the native anatomy is, but over many years of looking at CAT scans of ankles, they managed to find what an average type of shape of a talus and a tibia corresponding should be. So it has the natural curvature to accept the curve of the fibula. Like here, that little curve there is to accept the fibula. It also matches the normal contour. They come in various sizes, and because we have the luxury of using that patient-specific instrumentation, we have a sense of what size the patient will be depending on their activity, their size, etc. The base of the tibia, like I said, and same thing with the talus, it matches the patient's anatomy, and that's the key thing to decrease wear rates. Is the older implants, they have this tendency, or they had the tendency of wearing out quickly over time and potentially loosening, and that's because it didn't match the normal kinematics of the ankle. That is significantly improved, and the Vantage Exact Tech implant does have that. So like I said before, the Vantage ankle does a great job of mimicking native anatomy. There's two main types that are out there. There's a flat cut type, which is the bottom. If you look at the bottom of the implant, it's flat and has these angled pegs, versus the curved talus implant that matches the anatomy. Now, the studies have shown both do very well, but for me, what I like to use, I like the fact that they have a curved talus option, because with the curvature of the talus, by mimicking that, you have more contact surface area between the bone and the implant, but you're also avoiding what we call shear stress. So the horizontal stress that could happen in a flat surface, theoretically, with the curved surface, you have this curved dome that makes it harder to slide back and forth, theoretically decreasing the wear rate. So one of the big reasons I like this implant is the fact that they have this curved option that is very mimic and match to the native anatomy. So like I said, there's a lot of nuance to this, but that curved option in general is something that I like to use. Lastly, I mentioned that patient-specific instrumentation. So by using that CAT scan to analyze the patient's native anatomy, it significantly improves precision and also decreases operative time. If you recall that video, there were many steps involved in matching the alignment and anchoring the cut guides in place and making sure you had it correct. But with the 3D specific, patient specific instrumentation, these cut guides are 3D printed that match your anatomy, even down to the different bone spurs or bone loss you may have. And you just you slide it onto the native bone, and it fits in a good position because it's expected to from the CAT scan. And then you make your cuts, and it dramatically saves time and, like I said, improves precision. So that's the basic gist of it. That's a very bird's eye view of ankle arthritis and total ankle replacement. I hope that was educational, and I hope that provided you some information that you didn't have before. So I'm going to turn this over to Sally now to open this up to any questions, and I'm happy to answer any questions from the audience.
Okay, and thank you, Dr. Yerrapragada. That was wonderful. You can hear me, correct?
Yes.
Yes, okay, perfect. All right, so now we're going to go ahead and open up any questions in the chat or the QA, whichever one you prefer. You can go ahead and type them in the bottom. And I do want to let you know that this video is recorded, so we will have it available at Dr. Yerrapragada's web page within a week. And for everybody who emailed and RSVP'd tonight, I will also send you a direct link, so you don't even have to go look for it. But if you have specific questions. Okay, so here we have one from Charles. He says, this is tremendous. How long does the surgery take? I want to make an appointment.
So in general, on average, it's about a 2-hour surgery, give or take half an hour either way. And that half an hour of wiggle room is just depending on the patient's anatomy. You know, if there's a specific deformity that we're correcting, a ligament injury, or any adjacent pathology, you may add or subtract a little bit, but 2 hours on average is what I tell folks. And post-operatively, I let most of my patients go home the same day. Some patients I'd like to keep overnight just if they want to, or if they want to make sure everything is going well. But this can be an outpatient surgery as well.
Wonderful. So you do them both at the surgery centers and at the hospital?
That's correct. Yes. So surgery center and hospital both are equipped to do this type of procedure. But and the important thing is it's and after the surgery you're non-weight bearing, but that's using crutches or a knee scooter. So there's a lot of surgeries that are outpatient for that reason. This is no different.
Wonderful. Okay. Mike says, thank you. Very informative. How long after a cervical fusion would I have to wait for the ankle surgery?
So that's a good question for your spine surgeon, but in general, it would be at least 3 months, and it would be more about making sure that you have recovered enough from your cervical fusion to feel comfortable using crutches, assisted devices, a walking boot for a short period of time. That would be the main hurdle before moving forward. It wouldn't necessarily be related to the fusion itself. It's more about being able to handle the strains put on you during the recovery.
Wonderful. Okay, so Jan says very well presented, and I would trust Dr. Yerrapragada to do my surgery should I need to go that direction, and she thanked you. And then we have a question here from an iPhone. Do you have a clinic in Utah?
So unfortunately, I do not. But we have 2 clinics here in the Northwest Denver area. We have one here in Boulder, and then another in Broomfield. But like I said, I apologize. We don't have any opportunities or clinics in Utah.
Okay. Well, we'll just hang out here for a minute or so and see if there's going to be any other questions that come up. So far, we've answered 6. Oh, here we go. The outer area of my ankle is enlarged due to a break 60 years ago and numerous strains. I don't have a lot of pain, but the ankle has been unstable for several years. What might be done to improve the instability and occasional swelling?
So that's an interesting point, and chronic instability over time is a potential cause of arthritis over time. If you imagine a stable ankle only moves a certain amount versus an unstable one has a lot of motion to it, and over time that instability can result in arthritis. To answer your question about ligament issues, If you have arthritis that's significant and we decide to go down the path of needing an ankle replacement, I also at the same time would reconstruct and re-strengthen your ligaments as well. If you didn't have arthritis, but you still had this issue of ligament or instability, I would just perform that ligament reconstruction surgery with the goals and hopes of preventing arthritis down the line.
Thank you. Jim says, I have a combination of arthritis and a focal split in my peroneal brevis tendon in my right ankle. Do you also perform surgery for tendon repairs and tubularizations?
So, Jim, yes, I do. And I would actually recommend doing both at the same time. And in general, unless it's a very large procedure, I try to do as many things as I can in one setting to minimize the need for any future surgery. So, if you came into clinic and we discussed this and we talked about surgery, I would talk about the ankle replacement surgery and at the same time repair those peroneal tendon tears. And that's going to be important for you to maintain the integrity of your peroneal tendons, because with an ankle replacement, you maintain motion. So those tendons are still going to function pretty normally. So you want to make sure that those are as healthy as possible. I would address both at the same time.
Awesome. And Chad wanted everybody to know that the PSI blocks are made in Littleton, and the listeners might like to hear that they're made locally.
That's correct. So that's actually really one of the nice things of working with the Exactech team here is that they're based here. And because of that, the implants turnaround time is very quick. We, in terms of getting a CAT scan to that moment to getting the implants made, it's a very quick process. Within a week or two, actually, is the quickest we've seen it done. In between, what I do with the Exactech team and the design team, we have a meeting where we pull up the 3D images, go over the CAT scan results, and we brainstorm and talk about, is this the right size for this patient? And what if we made the cut this small? Would that be too small? And it's actually a pretty collaborative process. So, but yeah, like Chad mentioned, it's all done here locally, which is really nice.
Yen says, my ankles hurt when I get up in the morning. The pain goes away very soon after, but I have no previous injuries.
So that's it's difficult to say exactly what that could be, but if it does continue and persists and it really bothers you, it may not be a bad idea just to get an X-ray, and at least with the X-ray, you'll get a starting point to say, do you have arthritis? Do you not? Do you have something else going on? And that's a good starting off point to see, is there anything else that needs to be done? But it's not a bad idea to see someone and get an X-ray.
Right. Someone said, I have a fused ankle from the 1980s. I have considerable pain in that ankle, especially when I work it. Is this surgery an option to explore?
So that's a good question. So we can convert a fused ankle to an ankle replacement. That is possible. And it's something that I have done before. But what I will tell you is to expect that full range of motion again, that's unrealistic. And the reason is after a fusion, and especially after many years, your tendons, your ligaments, they're used to that fused position. So their normal motion excursion has been severely hampered. But like I said, that is possible, is feasible for the right type of patient.
And Charles would like to know, is the anesthesia general?
So typically it is, but in certain situations it doesn't have to be. Meaning, in all my patients, I do a regional nerve block where high up in your leg and your thigh, we numb up your nerves so that the ankle itself is totally numb, and that lasts for about 24 hours. So we can use that combination as well as the potential spinal anesthesia to allow patients to have as minimal sedation as possible to do the surgery safely.
Anne says your answer is very informative and helpful, and she thanks you for that. And someone wants to know if we accept Blue Cross Blue Shield of Illinois, and we do accept Blue Cross Blue Shield. They will all be just a little different in different states, but we could certainly look up all your benefits before you come in, so that way you won't have any surprises. Okay. Now we have another thank you. Okay, we'll just see if there's any further questions. And Jim would like to know if you're seeing new patients.
I am, yes, yes. So I see new patients, previous patients, all kinds. So this sparks anyone's curiosity or interest or concerns them that this may be something that they have. Like Sally mentioned, anyone is free to schedule an appointment. I'm happy to see you and give you a consultation, in my opinion.
He said, thank you very much. Very helpful presentation. Kelsey said, thank you. Dr. Yerrapragada is the best.
Thank you, Kelsey.
Do you find certain times of the year work better as far as recuperation goes?
So in general, it's really up to the patient, and it's more about the type of person you are or they are. Meaning, you're gonna sacrifice one season, and it's whether you want to sacrifice the summer season if you're more of a winter sports enthusiast, or you want to sacrifice the winter season if you're more of a summer enthusiast. So that's the kind of timeline you want to consider, is that there's going to be a 3 to 4 month period where you're not doing the things you want to do. After that, you'll be increasing your activity steadily and you'll be able to get back to it. So it's totally about what you're interested in.
I do have a question. I have no pain, but sometimes my ankle just gives way and I feel I might fall.
So Jen, that may be an instability issue, meaning the ligaments of your ankle, either from previous injury or recent injury, they may not be as strong as they once were. So that feeling of giving way, may just be a ligament issue. And if it keeps happening, especially if this is something that's causing you to potentially fall, then I think it's worth investigating and finding out. And it would first be with an X-ray, clinical exam, but maybe an MRI.
She would also like to know would therapy help with that?
So it certainly can, yes. So if you have a ligament issue and your ankles feel weak and you haven't tried physical therapy, that's the first thing I would offer someone, is to try to strengthen the ankle muscles around the ligaments that are weak to try to compensate for them.
She said, thank you. All right, and I think that is the end of our questions. If you do think of a question and you later on, you can certainly email me. I'm Sally. I'm the one you've been contacting with when you received your Zoom link. So you can certainly ask me the question. I'll get it to Dr. Yerrapragada. So if you didn't have a chance or you think of one later, we can do that. So I wanted to thank you all for joining us tonight, and thank you to Dr. Yerrapragada for his time and expertise in answering all the questions and presenting all of this great information. So I hope you all have a great night.
Thank you, everyone. Have a good night.